Dr. Ipsita will be presenting on a study on clinical presentation of patients with low vision and effectiveness of rehabilitation. You can start.
Good afternoon, everyone. I will present a study on clinical presentations of patients with low vision and effectiveness of rehabilitation. Informed consent was taken from all the patients. There was no conflict of interest and no financial support. The low vision essentially refers to a level of vision that prevents a person from performing customary visual activities such as reading, writing, orientation, and mobility, etc., even with standard or conventional optical correction. Few studies have shown that the prevalence of low vision is up to 60% among the elderly population. Such patients may be benefited by the significant residual usable vision with the help of low vision aids for day-to-day activities. A low vision aid is conventionally refers to a device that improves or enhances the residual vision by magnifying the image of the object at the retinal level or by modifying the environmental factors. The aims of our study were to study the common etiological conditions causing the low vision in patients, to study the demographic factors in patients with low vision, to study different best suitable low vision aids advised and their compliance rate, and to study the improvement in the quality of life of the low vision patients after using the low vision aids. This hospital-based observational prospective study was done in a tertiary care hospital in northeast part of the India in 1 year duration. All patients with BCVA less than 6/18 in the better eye, patients above 10 years to 70 years of age and stable ocular condition were included in the study. Patients below 10 years of age and above 70 years of age, patients with acute or progressive ocular disease not willing to use any LVA, and differently abled people are excluded from our study. Patients with BCVA less than 6/18 in better eye were considered as having low vision. 80 such low vision patients were thoroughly evaluated regarding the causes of the low vision and were given counseling and trial for different low vision aids. The best suitable low vision aid which had been accepted by the patient was advised. Each patient, whoever was advised low vision aids, were asked to follow up after 3 months. Patient's response was noted regarding quality of life before and after using the low vision aid and purpose of low vision aid use by a questionnaire. The quality of life was assessed by the level of difficulty in performing these 7 visual tasks. Each difficulty level was allotted score as extreme difficulty as 1, moderate difficulty as 2, mild difficulty as 3, no difficulty as 4, and stop tasks due to poor vision is 0. So the results shows the age distribution. The maximum number of patients were in the age group of 20 to 29 years of age, and the mean age was 36.6 years. Mostly the patients were male and mostly from rural areas. Among different etiologies, the most common etiology was ARMD followed by amblyopia, and the other causes were hereditary dystrophies, maculopathies, chorioretinal diseases, optic atrophy, nystagmus, and other causes. These are the BCVA for distance in the better eye on presentation. It was 6/18 to 6/60, which has the most number of patients, and this is the for near. Most patients were in the group of N8 to N24. Out of 80 patients with low vision, 58 patients accepted the low vision aids, and therefore the best suitable LVA was advised. However, only 40 patients showed the compliance, and they came for follow-up. So these are the different low vision aid advised. Among that, magnifying spectacle was the most commonly advised low vision aid, and the overall compliance rate was 68.96%. The compliance was highest for magnifying spectacle, followed by linear magnification. It was least for telescope. These are the purpose of LVA used, which was reported by the patient when they came for follow-up. So for reading related task was the most common purpose by the patient. The quality of the life assessment was done by depending on this visual task. So the post LVA mean score and the pre LVA mean score was compared. This shows a statistically significant improvement in the quality of life after using the low vision aid. This hospital-based prospective study aimed to identify the common etiological conditions of the low vision, demographic pattern, and the acceptance and effectiveness of the low vision aid. Our study found that the age-related macular degeneration was the most common cause of the low vision, followed by amblyopia. These findings are consistent with the study by Khan et al. Identifying the retinal disease as the predominant cause of the low vision. Pattern of advice of different LVAs were similar by studies by Khan et al. And Kim et al. Low vision rehabilitation is associated with the increase in functional status and improved vision. These positive changes are associated with personal and social benefits, especially increased autonomy and enhanced quality of life. As an individual becomes more independent and able to better perform routine daily activities, the severity of depression also decreases. These are my references. Thank you.
Dr. Das, it is a good presentation, but one thing is there. Can you tell me what was the problem with the vision when it was 6/18?
Actually, when it is like such a cutoff, the dependency increases.
No. What was the diagnosis of those patients? What disease they had? Mostly the patients with 6/18.
Yeah, there are different in the mostly there are different causes. Like some can be treatable, some can be the vision can be it can be better with refractive correction or any surgical methods.
Yes, but I want to tell you this thing. If vision is 6/18, it is better to treat the primary problem in place of directly going to the low vision aid. Because by the meaning of low vision aid, they will be more depressed. If they are having a refractive error, if they are having ARMD, should see it.
Ma'am, actually we have prescribed low vision aid when we have tried all the methods, like routine methods, spectacle.
But you have not mentioned that it is not improved with the
with the best corrected visual acuity 6/18, when after correction with the spectacle or any surgical method, whatever can be done, when with all the efforts we cannot improve the vision, then only we selected or counsel the patient for low vision aid.
As per the requirement.
Yes, ma'am. As per
the profession or the
occupation. Yes, ma'am. Whether they need the distance mode or near mode, according to that. And
Thank you. Nice study.
thank you.